TFC, triangular fibrocartilage complex. These so I can see. Triangular fibrocartilage complex, TFCC. Cartilage structure located on the small finger side. Right here. Okay, right in front of, that's your styloid process, the part that sticks out. So right in front of it is your TFCC. That cushions and support the small carpal bones in the wrist. So if we go back and we see those pretty small bones, they help cushion. Well, you'll have to look it up. It's going too far back. They help cushion and support those small bones. Bones are held together by ligaments, and you know that. So the TFCC keeps the forearm bones of the radius and ulna stable. When the hand grasps or the forearm rotates, an injury, tear, or tear to the TFCC can cause chronic wrist pain. One of the things that I've seen this in is rodeo. Those guys that do bareback, they actually have a saddle, but it doesn't have a seat in it. So they're sitting up on the horse's backside. They reach in, and this goes back and forth, as they're getting whipped around. And so anyway, that's where you'll find your TFCC. Small pinky side in front of or below of the styloid process. All right, two types of tears. Type 1 is a traumatic tear from falling on an outstretched hand, and excessive arm rotation are the most common causes. Yeah, he does. Bigger they are, the bigger the baby they are. Type 2 is degenerative or chronic. So type 1 is probably what you would see in athletics. Now, if you were working in pros, you very well may see type 2 if you get somebody that's been playing for 15 years and now it's chronic and it's degenerative. It can also occur over time with age. The degenerative process wears down the cartilage over time, and some inflammatory disorders such as rheumatoid arthritis or gout may also contribute to type 2 tears. So, what are the symptoms of a TFCC tear? Well, the common symptoms are pain at the base of the small finger side of the wrist, right there. Small finger side of the wrist. Yeah. Pain worsens as the wrist is bent from side to side, especially if you go with ulnar deviation. You get this out here, you'll feel it. So where do you think that these guys in, say, football feel it? When? What are they doing? Or lifting weights. Yes. Or pushing, right? So you get swelling at the wrist and a painful clicking in the wrist, and you lose your grip strength. So how are you going to do this? Well, you can put them in a cast. Those ligaments are so small, and that cartilage is so small, that's pretty much the only non-conservative way of helping this. Take anti-inflammatories such as ibuprofen, maybe a cortisone shot, maybe some ultrasound, but cast is the most conservative. Your rehab exercises, range of motion, just think of anything else. Just like when he gets his ankle done, He needs to do range of motion. He needs to do stretching. He needs to do strengthening. And so these are wrist specific of those. Wrist stretch. Again this way. Again here, here, full range of motion, and then strengthening. And then grip something. They can do that. You can also do a surgical treatment option. Generally needed those who don't heal or respond with the conservative treatment. So if you've got them in a cast and then 4 weeks, 6 weeks later you take them out and they're not any better, they go in and have surgery for this. All right. So you got an idea of TFCC. Not super stuff on the test. But you do need to know it. When you're taping somebody who has TFCC and they want their wrist taped, all right, what you'll do is you'll take a piece of moleskin and you'll come around their thumb and you'll actually pull it down to where you get radial deviation. You get it pulled over here and then tape the wrist. Then their thumb actually helps keep it from going over there in ulnar deviation. So we can show you that here after a while. Mallet finger, sometimes called baseball or basketball finger, caused by a blow from a thrown ball or hitting it at the tip of your finger, jamming and involving the extensor tendon from its insertion. Okay, our extensor tendons. We extend our fingers. Of course, you don't see it real good on me, but you find an old person. Okay, find an old person. You can see those strings in the back of their hands. They're extensor tendons. See if I can get it going. You can see those strings start going there. Her strings are showing up rather well. Okay? Just in the back of your hands. See how that string is coming up? Yep. You see your string? Here, here. So those strings or tendons, extensor tendons, they go all the way to the very ends of your fingers. So you don't just see them here. You see them here, but they'll continue all the way down. So when you pull that muscle, that's what happens. They open up. Well, huh? Are they all the way? Goes all the way to the tip of your finger. Well, it's not a muscle. The muscles are in your forearm. The tendons are what come down because just a rope. It's a whole lot easier to have a tendon there than have a big old muscle. Muscle's going to be bigger than the tendon. Well, your fingers don't need to be huge and fat. It might get that way in time, but oh well. But so you extend those. You get something hit on the end of your finger, and now you get mallet finger, where we'll show you that guy's extensor tendon has been knocked off the very tip of his finger. Well, all the way down, of course, it's glued down a little bit here and held down a little bit here, held down a little bit here. So from here back, it works. But the very end of it, it doesn't. And they call that mallet finger. So rice is given. You need to keep it in a splint, a finger splint, for about 8 weeks without taking it off at all, period. You take it off, you need to have another one ready to put back on. Because every time that this comes back down and turns into mallet finger, that means it's starting all over. So, Boutonniere Deformity. All right, there's that extensor tendon that's right there. What if I tear the extensor tendon here in the middle and not at the end? Yeah, you can move it. But what will happen is it will slide. So if I tear this in half this way, longitudinal, it will slide down to each side, and then it will go like that. So you try to point, and that's what you get. You'll get, that should be on the other side. You get this right here. So you've torn your extensor tendon on the top, and so the sides slide down, and then they allow this to go like so. That's Boutonniere Deformity. It's a buttonhole deformity caused by a rupture and extensor tendon dorsal to the middle dip. Occurs, forces the distal interphalangeal joint into the extension and the pip into flexion, and it causes this to look really funny like that. I don't know that I've ever seen one of those. You see any of those? Boutonniere. Yep. You'll see, yeah, you'll probably see one this year. Baseball. Wide receivers. All right, Gamekeeper thumb. Okay, I have a seat right there. So, Gamekeeper's thumb. This is a sprain to your ulnar collateral ligament. All right? So, where on your thumb is your ulnar collateral ligament? It's on your ulnar side. But is your thumb on your ulnar side or radial side? It's on the radial side. Another way that you so on the ulnar side would be this side. There's the ulna, so it's over here. So that ligament, there's a ligament that runs right here. It's super important, but you'll see football, baseball, basketball players get this thing torn up. Go in for a tackle. You go in for a tackle and you hit somebody on the shoulder pads, and boom, you've ruptured your ulnar collateral ligament. Try buttoning your pants. Try starting a car. So many things depend on your UCL of your thumb. Why is it called Gamekeeper's thumb, though? In the days of old, when knights were bold and royalty were the only ones that got to eat. If you two need to separate like you're in third grade. So, Shannon, you come over here. And if we have to do sixth grade behavior, we'll have detention. So the gamekeeper back in the day of King Arthur and so forth, he was the one that actually went out and got the food for the royal court. Well, back then there was a lot of pheasant, quail, etc. Well, if you don't go quail hunting, you should know, or you dove hunting. If you go dove hunting, you shoot the dove, and then you break its neck. And the easiest way to break its neck is to hold its little head in your deal and flip it over your thumb. And so those guys' thumbs would end up being stretched out. Gamekeeper thumb. Management includes referral. Make sure that there's no instability in the joint. If the joint is stable, you need an X-ray to rule out a fracture. The fracture that you would normally see here is an avulsion fracture, where the ligament is actually stronger than the bone. Actually stronger than the bone, and so the bone pulls off, and it looks like it's a sprain, but it's actually a fracture. So split the thumb for 3 weeks until the thumb is pain-free. Taping should continue throughout the season. Sprains to fingers is probably the most common injury in sports. It can range from everything minor to a complete tear of collateral ligaments. You're going to do a valgus and varus stress test just like if it was your knee or your elbow. You're going to find out how far that this ligament's been torn. Usually caused by axial force, a force coming straight on it, and then it's a segmented column. That column's got to let loose, and that's going to be at the weak spot, which is the joint, and you get too much varus or valgus stress. You'll hear them come in. I jam my finger. All right? So, PRICE for acute stage, X-ray to rule out a fracture and splinting, taping and return to deal. Dislocation, that's where you've gone past jamming your finger and knocking it out. You knock it out of the joint. It can occur either to your pip, your proximal one, or your dip, the distal one. Now, I tell you don't reduce fingers. Not until you've done it a few hundred times. Okay. I was really lucky that when I was in college, one of the guys that was playing offensive line, his finger would come out at least once a week, and so it was awesome. So once a week, he'd come up, his finger'd be out, and I'd take his finger, and then you put one here, and you roll it up and pull, and it goes right back into the joint. So this was pretty easy, but one, it gave me quite a bit of confidence on those, and then two, taught me to master a technique that worked out pretty well. So Rice, especially elevation, reduce the finger. If the finger, once you have it in place, you still need an X-ray to make sure it's not fractured. So we had this one guy, high school, up in Mount Pleasant. He comes to me and comes over and his ring finger's dislocated. He says, "Can you get this back?" I said, "Yeah." I said, "Just happened." He says, "No, it happened 4 plays ago." I said, "We're in practice." He goes, "I know, but it was my turn to practice." So there's a nice dislocated finger. So once it's put back in place, now what do you have? Sprained finger. Super. Set the note. There's a compound dislocation. I wish it was in color. I'll find one that goes in color. Compound dislocation is where the bone has ruptured through the skin. That is definitely got to be seen by the physician because of one, you need stitches, and then two, you have to worry about infection. So these are some rehab exercises, and for rehab exercises, not management, these basic exercises are useful for injuries for forearm, wrist, and fingers. We have towel twist. So Sarah, let's grab a towel. That's a good towel. And now what you're going to do is you're going to take that towel and you're going to end up twisting that towel and making it tighter and tighter and tighter. Mm-hmm. One's up, one's back. One's up, one's back. Here. Towel twist. Okay? Simple things to do that are cheap to find. That towel was used earlier today. All right, wrist rolls. We actually, I think Miss Bates made one over here out of a stick and some weight. And keep your arm straight, and you can do that. There's Theraputty in the drawer that works just like these. We don't have one of those, and I don't even know if they make those anymore. But it measures how much your grip strength is. Rubber bands. Here we go. So just like you've got a TheraBand, you can use a smaller one, a rubber band, and wrap it around your distal finger. Pretty easy stuff. You can share it with your other fingers, come across, and pull them apart. Pick up coins. You'll see that when you go to the stroke place, where if you've got people who are doing occupational therapy, find small coins such as dimes, just put them down on the table and have them pick them up and turn them all to heads. Then turn them all to tails. Seems to be it. Wednesday.